Thank you for joining us for Conversations in HIV, Patient Voices Guiding Physician Choices. During this segment, we'll be discussing my patient, an older male with HIV with comorbidities. I'm Dr. David Wohl, Professor of Medicine at the University of North Carolina at Chapel Hill, and I'm pleased to be joined by my colleagues, Dr. Meredith Clement and Dr. Amisika Nayaku. So let me tell you both about my patient. He's a 61-year-old male. He was diagnosed with HIV more than 25 years ago and had pretty advanced infection at that point. He had a very low CD4 cell count, under 50, and at the same time, sort of unusually, even at that time, had very low platelet counts, so severe thrombocytopenia, which was a real major problem for him during the first few years of his course. Originally, maybe around 50,000, and it started to drop even less than 20,000 to the point where we were worried about him having spontaneous bleeds. To be honest with you, at the time, we have to remember more than 2 decades ago, our choices for HIV therapy were fairly limited, and there were a lot of concerns about toxicity. Reminiscent to some of the conversations we're having today about therapies for things like COVID-19, there was a lot of hesitancy then about therapy. So maybe we could first start by listening to this man talk about his initial interactions and encounters and engagement with healthcare.
I wound up going to UNC Hospital and talking to like a social worker type. She said, "You have to start seeing a doctor." And I said, "The only way I can see a doctor is if I see somebody that's going to work with me. I am not going to do everything I'm told." I feel like, just being handed a bunch of medicine, it didn't resonate with me that that was going to be what I needed at that time. Well, I was taking this stuff that was from France, and it was some kind of derivative from the boxwood evergreen. The only issues I had in the beginning was I developed thrombocytopenia. My spleen got confused and knew something had to be removed from my body, so it started removing platelets. But other than that, I don't remember any kind of health issues that I was dealing with. So anyway, it was one day I was seeing Dr. Wohl, and he said, basically, he said, it's kind of like you're sitting in a car and you're driving and you're heading toward a cliff and your foot is on the gas pedal. And right now you're doing about 80 miles an hour. And that's the way he described, what was going on with my blood test results. And that was what made me realize that I needed help, as far as medicine.
Yeah, so it brings back memories for me.
Sure.
Certainly a metaphor I used a lot back then as we talked about the CD4 cell count cliff and having people understand why medication. Remember, we didn't treat everyone. We waited till the CD4 cell count dropped, and he was well below the threshold for starting HIV therapy. So maybe share a little bit about your, what rings for you in hearing about this person from even 25, 30 years ago to like today?
So I think about the clinical population that I take care of, and there's still a lot of misunderstanding of what it means to be diagnosed with HIV in terms of how well the treatments are going to work, what are the potential toxicities. And so that hesitancy to start medications is still very much a conversation that I have with many patients that are coming in with new diagnoses. And then on the flip side, because I do take care of a population of people with substance use disorders, there are individuals that have been living with HIV for a very long time, have been on and off their medications, and again, because they may not be so closely linked with HIV care, they're also not aware of the advances in HIV treatment or think that they aren't going to be able to receive that.
Mm-hmm.
I actually love that he said I needed to find a physician who would work with me, right? And I think that's so much of what we do is meeting the patients where they are. And sometimes that means meeting them halfway and compromising, but also just listening to them. What are their concerns and why are they having this hesitation? But actually what I was thinking of as you guys were talking is the difference that we're seeing now in 2024 when same day start is really like the standard of care.
Right.
And so you have someone who's newly diagnosed, comes into your office, and you say, I can start you on this single tablet regimen, you know, 1 pill once a day, incredibly effective, very few side effects, and you talk to them about U equals U, undetectable equals untransmittable. Sometimes in my office, I'm sure you guys have experienced this, people are in tears because they thought that they had been diagnosed with HIV and it was going to be life-changing, and instead it's 1 tablet once a day and they can go about their normal lives. They don't have to worry about sexual transmission to their partners. And so, I mean, it's incredible that things have changed so much in the past few decades, right?
Yeah. So I think we're going to hear again from this patient. So this is the next chapter in his story, which is kind of interesting too, in that he did get on the I need to be on therapy bandwagon, but I don't think he had both feet in the car. So let's listen to this next segment and hear a little bit about how he approached, from his side of things, starting on therapy.
I was taking self-prescribed dosages. And there were some people that were kind of freaking out about that. They were like, you can't do that. And Dr. Wohl seemed to, he told me that this is what I needed to do. But, like I said, the original premise was I was going to do what I felt I needed to do. So I actually think that helped me in the beginning. To this day, I believe that, most doctors overprescribe medicine. I think that, they're just doing what they know, and that's what they know. That's what they do. I think our bodies are, really capable of doing a lot. And sometimes medicine can be helpful, but too much medicine can cause damage.
So we've had a very long relationship. And like any long relationship, there's been a lot of give and takes. But this was sort of like, you need to, now I'm putting my foot down. You can't be taking half your doses of your HIV medicines because you're going to burn bridges and we're going to be back to where we started. And with time, I think he started to mature and understand that this was something he's going to have to deal with, and that the crystals and the speaking to his spleen and the things that he was doing maybe weren't working as well, and that this could be complementary.
I see that actually a fair amount with patients' diabetes or other comorbidities. They're gonna self-manage, take supplements, turmeric, whatever kind of herb or supplement that they see as something that can help them without medicine. And I understand it, right? Polypharmacy is a real thing that we, as doctors, we do overprescribe. And I've met patients who have, 20 medications they're taking a day, right? And that is exhausting for them.
I think the other part that struck me was the fact that even though there was a difference in approach, and you definitely were feeling the urgency that his health was deteriorating, there wasn't this sense of it's either my way or the highway. It was, I'm going to continue to be here with you, but at the same time, I also want you to know that I am really concerned that we're going to have unforeseen or preventable bad outcomes. And so this is why I'm hearing what you're saying, but at the same time, I do need you to do this a different way because I have this expertise, I have this knowledge, and we all have the same goal of keeping you healthy.
I think that you're exactly right. In this case, there's this balance between sort of a little bit of tough love, but also I felt and I think this comes up with difficult patients that we talk about, that you encounter all the time, is there needs to be some locus of control. He needed to be able to have something he could control, because giving him my antiretroviral prescriptions, he couldn't control that. So he controlled the doses. That was his lever to pull. Or doing these other things that he felt were important. That was his lever to pull. And people need that. And we see this all the time, especially with people who we see in the hospital, sometimes with substance use disorders or mental health disorders. When they lose control, there's nothing they can manipulate. They manipulate what they can manipulate. And that's a very natural human experience. So this went on, and actually we had some of those ups and downs, but things generally progressed very well. And as therapy, as you mentioned, got better and more convenient, he accepted it more. The other thing that really kind of was paradoxical to me is that he is a big-time smoker, and was very relaxed. He's like, I enjoy this. This is what I do. And even with his talk about chemicals and overprescription, he was smoking. And we talked a lot about how that didn't make any sense, but there's only so much you could do with that. And so that was also another thing that kind of was a concern. So maybe we could hear again, because I think we're now going along our pathway to get us more up to date.
I've always maintained good health. So it wasn't until January of last year I saw Dr. Wohl, and I said, something's going on here. And he took a look, and it ended up being anal cancer from the HPV virus. And I had that removed in February, and it did show that it was cancerous. And in April, for 5 weeks, during April and the first week of May, I had chemo and radiation every day. And the chemotherapy caused me to develop drug-induced interstitial lung disease.
So here we were going along, we were working on the smoking. He was continuing to work. We had, with the Affordable Care Act and other things, we were able finally to get his financial issues settled. So things were really smooth. We had this sort of honeymoon of grace period for many years where we were both happy with our results. And then did come in and said, I've noticed something on my bottom. And then I did look, and it looked to me clearly that there was a cancer there, and it led to this therapy course that I think really has been somewhat devastating to his health. So I think for here, the challenge for me was, and for many of my patients, is growing older with HIV, and now not turning your focus from the HIV to these other things, whether they be, impending COPD or hypertension or renal insufficiency, or in this case, a cancer diagnosis.
So we're a Ryan White clinic, and so one of the things as a part of being a Ryan White clinic is that we're supposed to be providing the primary care. But like you said, there is that reality of what does that look like in terms of different expertise based on the way that you enter into taking care of somebody living with HIV. And so kind of starting from the infectious disease side, and then as we understand more and more about how comorbidities look different in people living with HIV as they're aging, it has staying on top of the guidelines, but also understanding that those guidelines for the general population may not have been as tailored and as they need to be for our population of people living with HIV. And I think that this issue for your patient around developing anal cancer really highlights that fact of, very happy that we have the results from the ANCHOR trial now, but presumably at the time and over these years for your patient, that was really an evidence-free area. So I think that for me, ultimately, this case highlights that as we think about how do we comprehensively care for somebody living with HIV and understand that HIV may have been their starting point with us, but as we put the patient back in the center, there needs to be some revisioning of kind of the approach. And so what does that mean for us in partnering with our primary care doctors or partnering with other providers and making the healthcare system more easily navigatable for the patients so that we can be able to stay on top of these things.
You mentioned the ANCHOR study, and so I just wanted to mention that you guys probably saw recently new guidelines from on HIV.gov related to anal cancer screening for persons with HIV. So I think we need to remain cognizant of updates like that so we can treat our patients in the most optimal way, right?
Yeah, and I think this particular circumstance, which I felt really bad about, because our clinic, Ryan White Clinic as well, definitely being able to implement anal cancer screening is a challenge for many of us. So I think we'll hear from him again and maybe get a little bit more of an update, and I'll tell you kind of where we are now.
Well, one of my my things, I guess, I'm going to get on my soapbox is just to be conscious of the words that you use. And I've just always felt very strongly about that. And I think if doctors thought a little bit more about, how they word things, that it, subconsciously even it might be beneficial to people that may not even be aware.
So I think there's sort of a bitterness, but not something he wants to dwell on. But I do think what he's also talking about is now he has multiple doctors. It used to be pretty much just me. But now he's had a surgeon, and he's had an oncologist, and now he has a pulmonary doctor. And he definitely complains to me a little bit about some of these other folks who may not be as clued in. And I think he's been in sort of the cocoon of our HIV clinic, where things are a little bit different. He requires oxygen now continuously. So this has been a major change for him. But I do think as our folks get more frail, which is a really huge concept that I think is important, we think about how do we support them, because that's not been a model that I think in HIV care. We definitely have dealt with people who needed hospice, but there's this long period way before that we're talking about now, where we have to help people who are going to have some challenges for probably the rest of their lives.
What I found that has been helpful, because we are still seen as really kind of the pillars and experts for those patients that we have, that even though they're seeing these other providers, is the narratives in our notes. And so talking about the patient being exhausted because now they've missed this visit or that visit, or this provider is having a hard time with them, but we understand the backstory. We've been with them for so long, and so see this change and how all of the kind of psychosocial stuff that other provider may not have the time to have really delve into. And so when I'm writing my notes and adding that narrative, and then I peek back and see what happened at that visit, and I see, oh, that provider read my note. They understand a little bit more. But you know, to your patient and to other patients as well, of trying to make sure that they are seen as people first, is to understand that we're listening, we're trying to do better, and there is progress, and for them to continue to push us to do more, because it does make a difference. It makes a difference in how they see themselves, how they see the care that they're receiving, and ultimately how they're coping with whatever medical condition they may be experiencing, so that they can still be that person that does all of these other things, and oh yeah, they also have this other, you know, medical condition as well, rather than that being at the forefront of their identity.
Yeah.
But absolutely. And words matter, language matters. I love what you just said.
Yeah. So this has been a great conversation. Thank you so much for sharing your insights as I shared my experience with this man who he's very lovely, and I'm hoping that he continues to be resilient and do well, because I think resilience is the key it's the counter to frailty. But yeah, I think this has been very helpful for me as well to kind of consider some of these thoughts.
Well, and what a wonderful relationship you have with him. So
yeah,
thank you for sharing his journey.
Yeah, it's been a long. He was one of my first persons that I took care of as a fellow with living with HIV. So it's been for us getting older together. And those of you, thank you again for joining us for this segment. And please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credits, and to access supplemental slides, as well as other topic segments and case scenarios that we'll be discussing. So thanks again.